So everyone, this is the third lecture of my previous topic. So goiter. So goiter is what? It's a thyroid in which thyroid increase in size. So blood circulation toward thyroid is increased. So when you auscultate a thyroid, so we find broods due to increased circulation. And secondly, there will be pretibial myxedema, which I already talked about, and then there will be a clubbing, and digits become thick. See, this is a clubbing. Clubbing can be present in the lungs disease like bronchiectasis, in the lungs condition, respiratory condition, in the cardiovascular condition. So one of the cause can be hyperthyroidism. This is see how the patient present, and this is a thickness of the digits. See in the X-ray, this is the thickness of the digits, and this is also a thickness of the digits, and this is a periorbital edema. Now come to what the investigation, in which investigation we will do. First of all, more important is TSH level, which will be low because T3 T4 is producing more. So T3 T4 go to the pituitary and they send the message to the pituitary that our amount is more, now stop producing TSH. So TSH producing less, so TSH level will be less. So we will also check T4. Keep in mind T4 present in the form of bonded with protein or free form. So we always check free form of T4. T4 will be raised, and we check autoantibodies like TSH antibody, and then we do radioactive iodine uptake therapy. It will be increased because thyroid is using more iodine because it stimulated by autoantibodies. So autoantibodies give message, make more and more thyroid hormone. So how it will make? It will take the iodine. So when we do radioactive iodine uptake therapy, we do, so there it will be increased. So this is a thing. Now how we treat this patient? Actually we give the patient propyl thiouracil. It will stop the peripheral deiodination and it stop the conversion of T4 to T3. So this medicine we give the patient twice or 3 times a day because this medication have a short half-life. And we also use methimazole, which we give once a day because have longer duration of action. And both drugs decrease the production of thyroid by inhibiting the enzyme like thyroid peroxidase. We continue treatment for 6 months until thyroid hormone comes normal, and side effect can be the hepatitis. So in pregnancy, this is very important. In pregnancy, we use PTU in first trimester because the first trimester is for the orgogenesis. If you will give other drug in that trimester, so it can be iatrogenic, it can damage brain or respiratory or CIT. So in the first trimester we use PTU, and in the second or third trimester we can give MMI or PTU. And I'll talk about in the hyperthyroidism there will be tachycardia. So avoid this. We also use symptomatic treatment like beta blocker. Now what's the surgical option? The surgical option, if medical treatment is failed, then we use the surgical option, in which we use thyroid ablation, mean destroy thyroid hormone cells which are producing more T3 T4 with the help of therapy. So in pregnancy we will do subtotal thyroidectomy. In pregnancy we will not do surgical thyroid ablation because it can be teratogenic. So we will do what? Subtotal thyroidectomy. So for the eyes we will do what? We ask the patient quit smoking and eyes drop just to prevent the eyes dryness, and we ask the patient to use steroid topical steroid on the eyes and orbital radiation just to avoid the eye condition. So that's all about the hypothyroidism and the causes of hyperthyroidism. Hope so you will understand. So in my next lecture of endocrinology I will talk about the further things. Thank you.